Good afternoon, everyone. I am Jamie from NUS Development Office. A warm welcome to our NUS Giving webinar series. On behalf of the Development Office, thank you all for joining today's session, Person-Centered Care, Empowering Individuals Living with Long-Term Conditions. Before we get started, I would like to go over some housekeeping matters. Tap the Change View icon and switch to Speaker View to maximize your enjoyment in today's event. You may like to turn on the camera for a more engaging session. Please keep your microphones muted during the dialogue session to prevent any disturbance. During the dialogue session, if you have any questions for our speakers, please type them into the chat box and we will bring it up during the discussion. Breakout rooms are available after the webinar. If you are interested to have a 5-minute one-on-one conversation with the speakers, do notify us by sending a private Zoom text to Steffi in the chat box before the halfway mark of the webinar, and you will be assigned to the rooms accordingly. Please also note that we will be recording this webinar. Today, we are pleased to have with us Prof. Tai Xiong, Director, Center of Excellence for Chronic Disease Prevention and Management, NUHS, and Dr. Yu Tong Wei, Deputy Director, Center of Excellence for Chronic Disease Prevention and Management, NUHS. Joining our panel speakers in the discussion is Dr. Kavita Venkataraman, Assistant Professor at Sosui Hawk School of Public Health, National University of Singapore. They will be addressing the Wiesenhouse of Person-Centered Care to Lead a Healthy Lifestyle. Over to you, Dr. Kavita.
Thank you, Jamie. At the School of Public Health, our mission is to translate research into interventions and policies that will improve the health of communities. As a clinician and epidemiologist with substantial experience in public health practice through my work at the World Health Organization, I would like my research to produce real change. One of the areas that I'm interested in is outcomes and expectations of care from the perspective of people with disease. Faced with ever-increasing workloads, there is often a temptation to focus on the disease at the cost of the individual. In this context, person-centered care aims to restore the balance between the provider and the care recipient by respecting people with disease and their right to make informed decisions about their care. I now hand over to Prof. Tai Xiong to tell us more about this.
Well, thank you very much, Kavita. And look, thank you, all of you, for sort of joining us. And now that we've received our instructions as to how to participate in this afternoon's webinar, I thought what I wanted to do is to make sure that we keep this as informal as possible. And you'll notice, I think, that we're trying out some things that we've never done before. So I challenged the team today to sort of create these breakout rooms so that we can have little conversations. And that's supposed to be sort of mimicking the experience that we might have were we able to get together and have a drink together in the at the end. So if some of you came up to us and tapped us on the shoulder, we should be able to sort of have a quick chat. And that's very much about what we wanted to talk to you about today, because really what we're talking about is making human connections. But we're talking about doing it in the clinic, and it's something that we don't necessarily think about often enough. And I'm going to suggest to you that, in fact, if we don't do this, we won't get the best that we can out of healthcare. So this is what we've entitled our talk, Person-Centered Care, Creating an Incredible Journey for Individuals Living with Long-Term Conditions. If you just go to the next slide for me. What I thought I'd start off with is basically a quick discussion about what a national university health system is. And I think this is important because you hear us use this term almost interchangeably sometimes when we talk about the NUS, for example. And it's very important to recognize that the National University Health System is not just about hospitals and clinics, as you see up in the top left. Yes, we do have hospitals, and there are sort of several major ones, including the Ting Fong Hospital, the NUH, and the Alexandra Hospital. There are all these polyclinics that are scattered around the island, and we're building out these primary care networks. But more importantly, the National University Health System integrates a whole series of academic institutions that includes, at the bottom, you can see the word medicine there. That's the School of Medicine. And the School of Medicine trains the vast majority of the doctors that enter the profession every year. We also have a nursing institute that trains a large number of nurses that enter both at undergraduate level and postgraduate level, and they have become the caregivers of tomorrow. But we also have the Faculty of Dentistry, and very importantly, I think where Kavita comes from, the School of Public Health. So you can see, in fact, that the different parties sort of come together. And what I hope we'll be able to share with you today is that the work that we do in the school translates directly into the people that will run the healthcare system in the future, because we're responsible for their training, but also will actually provide the healthcare system now and tomorrow, so that where we have to modify the healthcare system, we're actually able to do that. And I think that's really the advantage that I have, at least, about being part of an academic medical system such as the NUHS. Next slide, please. So very quickly, I thought what I would do is sort of share a sort of very broad overview and talk about some of the key trends that will drive the evolution of healthcare. And the first one at the top left, you can see, is that Singapore has an aging population. And it has an aging population for one reason, and that primary reason is because we're not really reproducing ourselves at the rate that we would like it. So we know that the fertility rate in Singapore is only about 1.2, and that means that every member of the population and their partner will produce only about 1+ offspring, and that isn't enough to replace themselves. So at some level, what's going to happen with the long life expectancy that we see in Singapore, and Singapore has now one of the longest life expectancies in the world. The long life expectancy means that there'll be more and more of us dependent on a smaller and smaller number of people to provide for our future. This aging has a number of different impacts, which I think are really important. And I think if you start off at the bottom left of this slide, there's something called the epidemiological transition. And this happens in every country and every population as populations live to longer life expectancies. By and large, this is a socio-economic transition. This is not because of healthcare that we live longer. It's because of simple things, right? The kinds of things that our colleagues from the School of Public Health talk about: safe water, safe food, adequate nutrition, control of infectious diseases. And what happens is that people then live long enough to develop these non-communicable chronic diseases like diabetes, heart disease, cancer. And in fact, these become the driving burden of disease, and we need to make sure that we take care of these long-term conditions. The second is that as we get older and we suffer from these long-term conditions, you can see in the top right here that people spend more and more time in hospital. And what that means is that as the population ages, there's not only a change in the types of diseases we have to deal with, but in fact, there will be an increased demand for healthcare. And all of this occurs in the context of a workforce that is falling. So what I'm showing you at the bottom right is the projected workforce between 2014 and 2030. And you can see, in fact, the number of people in the workforce is expected to fall somewhere in the region of 30% over the next 15 to 20 years. And this is across the board, never mind in healthcare. And what I suppose I'm saying is that we're going to be dealing with increased healthcare demand in the context of fewer and fewer people who are able to provide that healthcare. Next slide, please. The other thing that I wanted to talk to you a little bit about is how we sort of transform healthcare. And typically, this is a figure that was produced at a symposium recently that talked about healthcare transformation. And what it shows you on the x-axis is the amount of money that we spend on healthcare systems, and on the y-axis, the amount of health that you get for that money. And one of the things that we keep coming back to is that the typical response to healthcare problems is surely the answer is just to spend more. And what I think this figure shows you, each of these dots represents an individual country. And what this figure shows you is that if you're a dot at the lower left corner of this figure, and you have very little healthcare, so if we live in a very deprived area in Africa, for example, increasing healthcare expenditure can rapidly increase the health of the population. And what you'll do is the health will increase along that green line. And that's exactly the kind of thing that we need to be doing. We just need to be increasing services and facilities to provide basic healthcare for the population. On the other hand, in the dark blue on the right-hand side of this figure, what you're beginning to see is what happens in developed countries. And then what we see is that as you increase healthcare expenditure, you don't see a very large increase in health. And the reason, I think, is because what we tend to do when we throw more money at a problem is to do more of the same thing, but try and work harder and do more of it, or in fact try to make it cheaper. And sometimes more of the same thing doesn't give you the kind of results that you want. What you really need to do is to change the way the care is delivered so that you can see a resumption of the trajectory along that green arrow. Next slide, please. So in essence, I think that the trends that will drive the evolution of healthcare, and these guide everything we do at the School of Medicine and these other schools and faculties that I'm talking to you about, are number one, that our population are aging, and number two, that this will increase the demand for healthcare even as the workforce shrinks. Just as increasing healthcare spending on trying to do the same thing better is likely to have limited impact on health of the population. And that's because to a large extent, we're stretching the limits of the technology. We must do things differently. And at the same time, the burden of disease will shift, or in fact, it has already shifted from acute conditions where you come in sick, you don't feel well, you get a treatment and it makes you better, and then you go back to your daily life and then you just carry on, to a chronic disease where we will be helping people live with disease rather than trying to cure them. And even cancer, which is something that a lot of people haven't thought of as something that you think of as either something you cure or that you die from, in actual fact is being transformed into a chronic disease because people can live for decades now and keep the cancer under control and live healthy, productive, happy lives. And our job is really to sort of see how we can enable that. Next slide. So here's what I'm talking about. As a school, as a healthcare system, in most developed countries, we focus on a couple of things, and we hear this all the time. We hear talk about this thing called evidence-based medicine. This is drilled into us as junior doctors and as medical students. And it basically supposes that there are different levels of evidence. Right? At the bottom, you've got sort of stories that my predecessors told me, and therefore I do the same thing that they did, and it should work. Right? At the top, what you've got is these sort of what we call these randomized controlled trials, where a lot of effort has been put in to sort of control for confounding and biases to make sure that when we say that a treatment works, we're really confident that it works and it's not something else. And I think those of you who've been sort of following the discussions around COVID vaccines and different therapies for COVID and should we use hydroxychloroquine are seeing an evolution of this process where we began at the beginning with just a few people saying, you know what, hydroxychloroquine is really going to work, to more well-designed studies that sort of said, you know what, maybe not. And then as you go into the vaccines, now we're seeing these randomized controlled trials that will tell us once and for all, does this thing work or not? And are we going to adopt it in clinical care? So that's on the evidence-based medicine side of things. And then the other thing that we keep talking about are these sort of things about value, cost effectiveness. If you're going to do something, make sure that you maximize the cost effectiveness. It turns out that this is something that health systems are very interested in, but if the individual patient may or may not be. Right? Then there are some patients who say, you know what, I'll make a choice of the therapy because I can't afford that. But that's really an access to care issue. Right? There are very few patients who tell me, you know what, this treatment is going to cost the government a lot of money and it's not going to buy me a lot of years of extra life. I think that I should give that up so that somebody else can have that same treatment. So both of these views are very provider-centric and physician-centric. Next slide. And if you think about it, when you take this kind of care and we deliver it, we tend to deliver it in a model that goes back to the 1950s. And this is the thing that struck us as Tong Wei and I began to sort of work on this. So if you think about the model that was described in 1950s, Parson actually described a role that patients are supposed to take and doctors are supposed to take. On the left-hand side, patients who are unwell are supposed to want to get better quickly, and they're supposed to seek help and cooperate with the doctor. Right? And when they don't, we call them non-compliant, or we use terminology like ill-disciplined to describe them. And you'll see these things appearing in the case notes. I'm not ashamed to say that I've used terminology like that myself. On the other hand, the doctor's role is to occupy a position of authority in relation to the patient. And we're supposed to be objective and emotionally detached so that we can take evidence that is entirely based on science and say to the patient, you know what, this decision that I'm making for you is based on science and I'm confident that it's going to work. So I think that model works really, really well in some instances, and I'll take you to the next slide and I'll show you what that is, right? And it works really, really well in the context of acute episodic care. When a patient is afraid and when they're in pain and when they don't know what to do, the last thing they want is for a doctor to come and say, you know what, I'm going to put this evidence in front of you, you decide what you're going to do. And in fact, even in Parsons' time in the 1950s, he describes this, that the supportive nature of paternalism, right, this business of being authoritative and objective, the supportive nature of paternalism appears to be more important when these patients are very sick. And that when you provide this kind of care, the relief from the burden of worry is curative in itself. And the trust and confidence implied by this model allows doctors very often to perform what appears to be medical magic. Right? It's what we call today a placebo effect. But it's really important, and there's a context for this. And when you think about why the healthcare system in Singapore was created, or indeed why the healthcare system in any developed country was created, it was by and large meant to deal with these acute episodes of illness. That's not the case today, as I've already suggested to you. Next slide, please. Today, the major burden of disease are not these acute illnesses. What you see is that if you look at overall the burden of disease in Singapore, they're all chronic diseases, and you see diabetes right there on the top. Diabetes is number one contributor of the burden of disease in Singapore. Next slide. So why doesn't it work? Why doesn't Parsons' model work? And here's how we think about it. We think that the reason it doesn't work is, unlike the hot patient in hospital who's desperate for some sort of form of relief and confidence that the doctor will do something to relieve their suffering and their pain and their concerns, patients with diabetes are not lying in a hospital bed. And in fact, in the early phases of disease, they're perfectly well. They have no symptoms whatsoever. And what they're doing is doing stuff that you see on the right. They're going about their daily lives. And if they eat, they don't eat because of the nutritional value of the food. Very few of us go out and choose a food because, you know, we're desperately short of a particular vitamin or mineral or nutrient that we need. Eating behavior is a social behavior, and it satisfies a whole series of psychological and social needs that really have nothing to do with nutrition. What I'm trying to say is that human beings with these long-term conditions, because they feel well, are going about their daily lives, and they're making hundreds of decisions every day. And those decisions are guided not by their health or their biological requirements. They're guided by individual factors, what they prefer, what they like, also around the context around where they are, what's available, what they walk past, and other sectors of influence, their friends, families, and also what's normal in their community. And it's very important for people to feel that they are part of a community and relate to others and do the same things that others do too. Next slide. And as a consequence of which, right, this has a consequence. When you take a model that's designed for one context, an acute episodic illness, and apply it to another context, a chronic long-term condition where the individual is living free in the community and making decisions based on things that have nothing to do with the disease, when you ask people about their long-term conditions, do you feel satisfied with the care, they usually say yes. And is the healthcare provider respected and valued? They usually say yes. Right, so I think that's a tribute to the doctors and the professionalism that we show. But when you ask them, do you have relevant information that would enable you to make the right decision at the right time that suits you, that becomes a little bit more ambiguous. And then when you ask them, do you feel listened to and involved in your care, you're starting to get no. Do you get consistent joined-up care? No. Do you do what you're told? No. Do you take tablets you're prescribed? No. Are the outcomes as good as can be? No. And I thought this whole idea that people don't take tablets as they're told is actually fundamental to the idea that we need to deliver care efficiently. So it fundamentally impacts on the efficiency of the healthcare system. And maybe one of the reasons why, as you increase healthcare expenditure, you don't see improvements in health. Writing a prescription doesn't improve a person's health if the individual doesn't take that medication. But if he or she doesn't take that medication, you have to believe that he or she has a good reason for that. And we need to begin to sort of explore those things. Next slide. Right, so what we've begun to see, and this is our new chief executive, Professor Yeo Kei-Guan, took over as chief executive of the NUHS last year, and he said that over the next 5 years, these are the four areas that we're going to do. And in terms of caring for our patients, what he described was we want to provide incredible care. And I think the question that we've been asking ourselves is, well, what does this look like? What in the world what will make care in the NUHS incredible? And I'm going to try and answer that. Next slide. It turns out that our patients tell us. So this is data now from the Ministry of Health, who went out to a whole group of diabetes patients across all sorts of settings: primary care, GPs, polyclinics, hospitals, private sector, public sector. And they asked them about their experience. You can see in these bubbles what they said about their care. And I think you can see actually why people feel that they don't necessarily feel engaged in the care. They don't feel as though they're involved in the decision making, and why they might not do the things that they've been asked to do. But on the other hand, they do describe an ideal experience. They say that they want to understand their current condition and the importance of managing it well. They want to have time to process their emotions after receiving the diagnosis and to consolidate the questions. They don't want to be told in the office, hey, look, your blood sugar is high. Now what do you want to do about it immediately? They want to have time to sort of process that information. There are emotions involved, and all of human beings do have emotions, and I think it's important to give them the time. And they want to feel heard and respected by the care teams and have their concerns addressed. And what we find as we go do this is that every patient has a different concern, even when we're talking about the same thing. Next slide. And then when it comes to what they will do, so this is goal setting, customization, and self-monitoring. You can see again all the things that sort of serve as barriers, which if we don't address them, you can immediately see why these things don't happen. But they also say they want the care team to know what their values and priorities are. Right? They want to feel confident and committed and ready to take the step before they're actually told to do it. And that the goals they set are important and realistic. And they want to know how to begin to customize their own habits rather than just following somebody's instructions. Right? And that they know how to work around potential obstacles. And you'll recognize immediately that the detached, objective, science-based approach that we've been taking in the hospital when patients are very sick really don't provide this ideal experience. And the question that we've been asking ourselves is, well, how do we do that? Next slide. And what we've come up with is really sort of nothing sort of magic. And this is not our model. This is the chronic care model that was developed by a chap called Wagner in the 1980s. And what he says, if you look at these two bubbles at the top, is that all the elements of excellent care, evidence-based medicine, cost effectiveness, all of them are important. None of them can go away. But what's important is that you bring them around a conversation between an informed and empowered patient. So we need to tell our patients, your views are important. Your aspirations are important. Your concerns are important. We need to acknowledge those concerns. And what we need to do is then be prepared, a proactive practice team, so that's the providers, and turn these office visits into what we call care and support planning visits. And we think that ultimately what this will allow is for us to bring all these elements within the healthcare system and deploy them in a way that actually improves outcomes, such that as we increase our healthcare spending, we do get incrementally more outcomes, and much more so than we're getting today. Next slide. So there's some theory around this, and I'm going to show you one here. And this is something that we call self-determination theory. And self-determination theory would posit that, in fact, every time we do things is driven by a certain degree of motivation. And that motivation has a continuum. On the left, what you find is somebody who is amotivated. So somebody who has really no interest in doing something that we're talking about, right? So it's non-regulated, it's non-intellectual, they just don't do it. And then sometimes we can move towards this external regulation. And what we're talking about when we say external regulation, what we're talking about is compliance, external rewards and punishments. You've seen sort of things where we sort of say, well, what if we pay people to do exercise? Right? And that's a classical example of external motivation. It might get them going, but it's unlikely to be sustainable. Right? Another external motivator might be, when I go to the doctor, my doctor will scold me. Right? And that's an external motivator. It might work for a day or two, and then but it doesn't sustain. So what we need to do, we think, is we need to move people towards a motivation that is purely intrinsic. So people will do something just for the sake of that doing. And I always give this example. And that was when I started going on the treadmill every day. It was by far the most boring thing I could imagine, and it was a torture for me to go. But I went because, I wanted to look good to my friends or my family, or I wanted to lose some weight or something like that. But once I'd achieved that, it became very difficult to continue. And what I found was, in fact, what I needed to do was when I went on a cross trainer was to take a book with me. Because what I was finding is that I really enjoy reading, but I didn't have enough time to do it during the day. And my exercise session then became my alone time to do something that I really wanted to do for its own sake, which is read. And that became an intrinsic motivator. And that kept me going for years, right until the circuit breaker. And I'll be honest with you, I still haven't dared to go back to the gym today. So I now do something else. Next slide. The other thing about motivation, and this comes from the same theory, is that in order for this shift to take place, in order for you to move towards something that is externally motivated to internally motivated, we need to satisfy three basic human needs. And these three needs are autonomy, competence, and relatedness. Let me tell you about these things. So autonomy basically it describes the need to control the course of our lives. So again, if we are completely prescriptive in the clinic and we tell our patients, this is the medication that you have to take, and I really don't care if you're worried about it, you just do this because I think it's the right thing. This is the most cost effective, and this is what the evidence suggests. We take away that autonomy, and they don't feel an ability to be motivated. Competence is about the need to be effective in dealing with the environment. They must feel that the goals that they set are something that they can do. It's not something that the doctor thinks they can do. It's something that they feel they can do. And if they don't feel they can do, we need to make sure we give them the skills that they need to actually feel this way. And then relatedness, I think, is about the need to have close affectionate relationships with others. I've talked to you about this a little bit earlier on, but we see some real examples about patients who during the circuit breaker have said, you know what, when I was at work before and I ate lunch on my own, I could just eat whatever I want and I could choose a healthy diet. But now I eat with my family and I feel a need to eat with them because that's part of the emotional bond that I have with the people that I've trapped in this house with. And now I'm no longer able to eat the diet that would be best beneficial to my health. This is relatedness. We must address all these needs in order to see motivation move from amotivation to intrinsic motivation. Next slide, please. Right, and what that means is that we need to rethink evidence-based medicine. Now, I'm going to end this as soon as I can by just saying that evidence-based care today is not about the evidence. It's not purely science, but it's about responding to the patient's problems with evidence. And that requires for you to understand, first of all, what the patient's problems are. And I think what we're going to do now is to take you through a journey that has led us to a path that we think will be able to deliver the promise of what we think an incredible journey should look like. Next slide. Okay, so this is all very nice in theory, but is it actually possible to change anything? And this is where I hand over to Tong Wei. Tong Wei is the Deputy Director of the Center for Chronic Disease Prevention and Management. But more importantly, when I was head of endocrinology, Tong Wei was a junior trainee who went away and decided that this is what he wanted to train in when he went to Scotland. He came back and he's really single-handedly sort of pulled all this together and pulled all this off. Tong Wei, over to you.
Thank you, Yishong. So I'll continue from where Yishong stopped. So I'll first describe to you how my consultations used to look like. So when my patients come to the clinic, they have a finger prick to check what we call a HbA1c, which is a reflection of the glucose control for the past 3 months. So, and then they sit in a waiting room without knowing the results. And they wait until I call the number. So when they come into the room, I usually start off the conversation by asking how they've been for the past few months. And then I will ask them, do you know what is your HbA1c today? Oh, that's actually a BS question because they've been sitting in the room and they don't really know what's the results. So I'll ask the question and then they will invariably say they don't know. And then I'll say, well, your HbA1c today is 8.1%. And then they'll look confused. And I'll ask them, do you know what's the ideal HbA1c for you? And most of them will say no. And say, well, it's ideal to keep it under 7. And yours is 8.1. So they'll pause for a while and then they will start coming up with excuses. Like, you know, Dr. Yu, I've just had a cup of coffee with sugar actually, and maybe that's the reason why my HbA1c is 8.1. So then I have to explain to them that no, it's a reflection of your average control for the past 3 months. So what you've just had would not actually impact on the results. And then I'll go through a long list of checkboxes that I need to cover within the 5 to 10 minutes consultation. You know, I have to see whether they're taking their medications, whether they're having some side effects, whether they monitor their glucose, what's their blood pressure, what's their cholesterol, how's their eyes, their feet, their kidneys. So it's a long list of checkboxes that we as a good doctor, you know, will need to cover a comprehensive assessment. So then they will, you know, get their medicine and they'll go away, and 3 months later they come in, the same cycle repeats. So when I talk about A1C again, they will give the same excuse as if I've never talked to them about that. So you can see sometimes the things that we think we have done actually makes no impact if it is done in a way that will not be effective. So so I look like the duck on the left, where I'm paddling hard and really to cover so many things in the consult. On the other hand, the patient most of the time come unprepared. They are not aware of the results. They don't understand what the results mean. Even if they understand, they will need time to process, like what Yi Xiong has described to you. They will need time to process. They want to look good in front of us, and they may be in a bit of denial. They are not sure what to discuss. Even if they know what to discuss, sometimes they are not sure how to start a discussion. This may be due to previous experiences or years of experiences that have been dealt with the healthcare system, that they may think that this thing is not related to my medical condition, because this is maybe something to do with my family, my mood, my job. So maybe the doctor is not interested, so I shouldn't bring it up. So they're not sure whether it's relevant. And then sometimes they forget to ask until they leave the room. And there are a lot of untapped resources in their lives that we as medical personnel don't know of. So they are like the frog, right? After a while, they say, well, whatever. So these medical consultations will then very pitifully turn into just routine exercises that they come and collect medicine and go back. Months later, they come and collect medicine and go back. So nothing very meaningful really happened. So we are quite good at doing things to the patients, but maybe not so good at doing things with the patient. Next slide. So what we have done is actually, if we can sum up in a phrase like this, is to transform consultations into really meaningful conversations, that things that really matter to the patients, and then things that can lead to effective changes. Next slide. So this is a diagram illustrated by someone living with a long-term condition like diabetes in a World Cafe event. So the green wavy line is actually representing the lives in a year. So there will be ups and downs in their lives, right? So there could be bereavement, they could have lost their job, they could, have wonderful events that's happening that represents the up. And then the orange vertical bars actually represent the regular medical appointments that they have with us. So you can see that they are evenly spaced out, 3 monthly, for example. So there will be like 4 visits in a year. And these consults could either coincide with events in the life where they really need help. For example, the second orange bar, where it coincides with the downs in the green line. But sometimes they may be just doing very well, and the consult really is not really that needed during that time. And you can see that the time that they come in contact with us is only at max 4 hours in a year, and they need to be on themselves, doing self-management to decide whether they're going to swallow this pill, whether they're going to do the injection, what food to choose, whether they're going to increase their physical activity for 8,756 hours in a year. So that's the reality of someone living with a long-term condition. So what we aim to do is really to maximize the contact, which is the orange bar, which I circled there, to maximize the effect, to achieve a meaningful outcome, so that can support them in self-managing in the rest of the time in the green line. Next slide, please. Another paradigm that we want to adopt, a bit different from the Parsons model that Yi Xiong described, is that we view this meaningful conversation as a meeting of 2 experts. Doctors, healthcare professionals, we are expert in the medical aspect, right? So we are, occupying sort of a higher ground in that knowledge and the things that we know. But we want to elevate the patients in that sense. On the other hand, patients are experts in their own life, so they occupy a higher ground compared to us. So we really want to catch up with them about their lives and their resources and things like that. So that meeting become the patient bringing their individual story and us as professionals bringing our agenda. And we really want to meet at an equal level to negotiate the agendas and the action plans to support them to live better with diabetes. Next slide. Also, we want patients to really feel safe. Now, this is an analogy that if you are familiar with psychological safety in organizational culture, it's the same thing that happens in the consultation room. Sometimes patients tell us that, they feel like a delinquent student going into a principal's office when they come into a doctor's office. And we don't want that, really. We want them to really feel safe so that the issues that really matters can be brought up to the table, whether or not they think it is related to medical stuff, because sometimes those may not be, but they may actually be the most important issue to solve for them to be able to self-manage effectively. So we want them to be able to feel safe to bring those onto the table for discussion. Next, please. So next, I will describe to you how do we achieve those things. So it's a very simple tweaks in the way we carry out the consultation appointments. So before, once a year, we want to engage them in what we call a care and support planning conversation. So before that visit, we invite the patients to come into the clinic to do their blood tests, have their weight, blood pressure, and so on measured 2 weeks before the appointment. The reason we do that is because after they do the test, we want to compile the results into what we call results or agenda setting prompts. A document which we send to them about a week before the conversation so that they have enough time to process, to digest things that they're not sure they can discuss with the family or they can read around on their own. And then those patients with even better efficacy may come out with explanations of why certain results go in a certain direction, and then some may even go as far as start to think about solutions for themselves. Then we invite them to come in for the care and support planning conversation, where we adopt the paradigm of meeting of equal experts. We train the healthcare workers to conduct these conversations in a really very collaborative way. A lot of principles that are borrowed from motivational interviewing and some generic good communication skills, coaching skills, and things like that, so that we can really get the issues out from the patients and then plan, set goals, and develop a plan together. Next, please. So I described earlier on that, some patients have had interactions with the healthcare system for years and they don't believe that, we are willing to do this with them. So we really have our coordinators tell them that we are really ready to do this. We prepared videos to tell them, we use personas that probably would resonate with them and tell some anecdotal stories. And then we really invite them to prepare themselves and come in to have a collaborative conversation. Next, please. So I'll show you what the results and agenda setting prompts look like. Next, please. So this results letter is designed with our patients. So we actually have focus group discussions with patients from different language and cultural ethnicity backgrounds. And they gave us some really interesting ideas. Next, please. So the page on the left here, you can see my face there. And this is actually an idea given by patients. It sounds like what you're trying to do is that the conversation actually happens, actually starts right before I come and see you. So the moment I open up this envelope with this results letter, it feels like the conversation has started. So why don't you put your face there with this conversation bubble, and we ask them a very high level question there. What's important to you? What's important to you in life beyond medical? Take a step back. What's really important? We want them to see the big picture and what health actually, why health actually matters to them. And if they can't answer that really high level question, we zoom down a bit. We give some suggestions that issues that concern people living with diabetes. In the second part, we list them down. We ask them to circle, and from there, maybe they could think of something that is really they want to talk about. Thirdly, we deliberately ask them about their mood. Now, in a very busy clinic that we have really not enough time, or really like the duck that is, paddling really hard, I myself was guilty of this. We sometimes really consciously avoid going to asking the mood, because once the Pandora box is open, the clinic is gone. We have to like spend 1 hour with the patient, dealing with this. But here, because we have committed to this, we really ask them whether they have anything that's disturbing their mood, because sometimes that can be the sole reason they can't self-manage properly. Then at the next page, you can see that we want to highlight things that they have done well first before we show them on the second half of the page in orange, red, orange, that the areas that may need improvement. Because many a times we always focus on the things that still need improvement, but we forget that that can be very frustrating to the patients. And there are some positive things that we really can give some affirmation to the patients. Next, please. Next, we show them all these important things like blood sugar control, the cholesterol levels, blood pressure. Next page. Smoking status, weight. And with all this, there's a brief explanation down there to explain what that means, And then with this traffic light system, very visual, give them a trend of whether they are improving, worsening, or they are keeping the same with this color-coded risk. And that could sort of trigger some responses when they see that. Next, please. And the final page is used during the conversation to really set goals and action plans that's meaningful with the patients. And we may also, ask them like what might stop you to carry out this action plan. So these are mental rehearsals of the barriers that may crop up so that they don't immediately back off when they face these barriers when they go back into their lives. Next, please. With that, right, we see that patients are better prepared and to carry out a more equal kind of conversation. So when they come, we use lots of collaborative communicative skills to talk to them. Next slide, please. So in essence, we really want to turn the consultations into meaningful conversations by better preparation for the patients and also the physicians. Decompressing the consultation means that we don't want to spend the precious time to explain what is the A1C, and also we do that all using the results letter, and we use a collaborative communication style. With that, we support the patient to better self-manage on the green line. Next slide, please. I would like to illustrate this with some patient anecdotes. I think those are really interesting anecdotes. Next, please. Shanti is a lady who all the indices are in green except for one, which is the LDL cholesterol. So without this model, right, usually how I did this was when patients come in, I will tell them, well, your LDL cholesterol is your bad cholesterol, and your result is 2.8, whereas the target should be 2.6. So I think you should take a cholesterol lowering medication. And then the patient say, well, what is the side effect? Then we'll go into explain all those. And then the likelihood of the patient to take that is really quite low, because when you listen without a visual representation, 2.8, 2.6 is really about the same. But for Shanti, with this, right, when the minute she came into the consultation room, the first thing that she said is, well, Dr. Yu, everything is in the green, only this LDL cholesterol. Can you tell me what can I do? So you can see the table is turned around, and I just need to very gently say that, the cholesterol lowering medications are really effective. If you take them, you will lower it. And then you can see that the likelihood of her taking them is significantly increased because she herself asked for it, right? Next slide, please. Madam Lau is a Chinese-speaking lady in her 60s. So she has two daughters. The elder one is already married, and she's living with a younger daughter in her 40s who is single. So they are really life companions for each other because she's a widow. So they travel yearly, they really accompany each other. And when we asked her that high-level question, what is meaningful to you? She said that she wants to live long and healthy and be independent so that she has more time to continue to be the life companion for her younger daughter. So that really makes her reflect and sees the big picture of what health means to her. And then everything else becomes really easy. Now, how to target your sugar, your cholesterol, your blood pressure, how to avoid complications, and how to do that. All will then focus back to this big picture and the big goal. And that really drives the intrinsic motivation that Isha mentioned earlier. Next slide, please. Madam Fatima is a story which illustrates that, patients sometimes are really the expert. Really, some of the solutions I myself cannot come out with them. So Fatima is a Muslim patient, and it is a norm for her to carry out, to sort of organize regular extended family gatherings. And when they gather at her house, she will make lots of kuehs and sweet drinks and things like that, which is really culturally appropriate. And if we adopt the traditional model, we will start telling her, don't eat all these things, or just prepare salad when you gather, and all this will not work, right? And she would say that it is actually very rude for me to not eat if during these gatherings. So I really, held back myself and not to try and jump in and give a solution, but support her to start to really explore what are the things that she can do. And eventually, the solution that she came up was, Muslim patients do fast outside of Ramadan to gain religious merits. So the solution that she came up with was like, Dr. Yu, I know what can do now. So I will fast during the days that I organize these family gatherings. So I will make the same food, the same drinks, and I can announce to my family that I'm fasting today, and therefore they will not feel that I'm impolite for not eating and all. So I can still socialize, but I can now, still have a really a good way to avoid all this unhealthy food that is bad for my diabetes. So these kind of solutions really cannot come out of me. And the patient is really the expert, as illustrated by this example. Next, please. Ishok mentioned about the huge cost of medications, and the picture on the lower right here is shared by our community nurse who does home visits. And it's very common scene to see these medications pile up like mountains in the patient's house. And they a lot of them don't really take it. So it is the same case for Michael, where he's actually on this 1, 2, 3, 4, 5 medications for diabetes, and his condition really warrants this to have a really good glucose control. And you can see that throughout the chart on the left, from September 2019 to June 2020, there was really no change of the medications, but you can see that there is really a gradual improvement in the glucose control, up to a really excellent level of 6.2 June this year. And all this just as an effect of, this collaborative conversation, and he starts seeing the effect of feeling more energetic, able to interact better with the family and at work, able to better perform at work because of a better glucose control and better level of energy, that he is now diligently taking all these medications, and that make our patients, benefit from the evidence-based medicine that we're talking about, rather than just us doing things to them, simply prescribing the medicines, but all these medicines go into the waste. Next slide, please. Guilt is a huge thing. I described the sense of guilt in a lot of patients. And Nurul, when she came in and we started this open conversation, she was rattling off with words like, I feel bad if I eat something bad in the day, and at night I really cannot sleep well, and all these things. And then I asked her, do you realize that all this word full of guilt that you use? And she really didn't realize it. So in this conversation, sometimes we serve as a mirror to reflect these things back to the patient. And once they can deal with that, they can deal with self-management much, much better. Next, please. So we did some evaluation. Next, please. And there's really significant improvement in shared decision making that patient report, using this score. As you can see, the steady increase. Next slide. And then a very interesting thing is like they really, this paid questionnaire assess the distress level from diabetes. And you can see after the first consultation, the distress level actually increased because all the issues are now brought up to the table. But over the year, you can see that all this distress dissipate very nicely and the distress score reduce. Next slide, please. And there is improvement in glucose control. Next slide. Cholesterol, blood pressure. Next slide. And also the proportions with all these indices that are improved. Next slide. And from the healthcare professionals, there were really very nice experience that are reported as well. And that really, deals with the burnout and, increase the satisfaction of the healthcare professional. Next slide, please. So in our journey started when we gotten some funding, and then we really need to carry out training for our professionals. We invited the team from the UK. Next, and then we expanded the program to the polyclinic, and even during the COVID times, we supported and we pressed on with this kind of conversations. Next. And we supported our colleagues in primary care in running this. We communicated what we are doing in the academia by publishing in journals. Next. And just to summarize, essentially what we do is, next. We start off with a clinical problem, which largely described by Yi Xiong. We base our interventions with some theory, mainly shared by Yi Xiong as well. And then we make all these seemingly small but really crucial tweaks in the system. And then we rigorously evaluate what we do and what effect that has. And then we communicate this to the community, and we scale this to have a larger impact on our patients, and we continue to refine this. So I'll stop here for the moment, and I'll hand over to Kavita. Thank you.
Thank you, Prof. Thai and Dr. Yu, for this excellent presentations and the detailed insights into the need for person-centered care and how such care could be operationalized. Just to summarize some of the key takeaways that I got from both of your talks is that there's the shift in disease burden and therefore demand from the health system from acute episodic care to chronic care and support, perhaps over a lifetime. And this means that we need to fundamentally change the way we practice medicine and interact with patients in order to increase the effectiveness of the work that we do. And patients actually have a very clear need for information, for time and space in order to process this information and cope with what is being shared with them. And they also have this need for respect of themselves as persons, their values and their priorities. And as person-centered care, when patients are provided adequate information, when the care consultations are transformed into meaningful conversations between two experts with an open acknowledgement of the strengths that each brings to the table and the limitations, we can actually see that patients start to take ownership of their own health and their care. And some of the transformative experiences that Dr. Yu has shared of individual patients really exemplifies that point. I do not see any questions in the chat, so I'll start off with a question of my own to the both of you, if I may. As you rightly pointed out, and healthcare delivery has largely been paternalistic for a very long time. How much of resistance is there on part of the providers and even the patients to change the paradigm?
Tong Wei, do you want to try that one first?
Actually, in our experience, the patients get it really very quickly. It's almost like they are waiting for this, but sometimes they don't know that they can have this until they're given an opportunity. And they're really appreciative. So I have really wonderful, many more wonderful anecdotes that I wish I can share, but because of time limitation, I can't do that. Professionals, the barriers are usually, they are brought up, we are limited by time, whether the system allows us to do this, and therefore the changes that enables this to happen is really important. And when that happens, what we hear frequently is they are really delighted for being able to do what they wanted to do when they entered medical school. And over the years, because of the way the entrenched system disabled them from doing this, having this kind of meaningful conversation.
So, I mean, Tongwei, thank you for that. I mean, I think you're absolutely right. I mean, I'm interested in that question, and people ask that question, and it turns out that the healthcare professionals is maybe one part that is the hardest to change. And a big part of that is really sort of not just engaging healthcare providers, but also to engage the hospital leadership. So it's a really powerful message to us. I think that last week, as part of the our chief executive sort of plans for the next 5 years, he sort of released this memo that basically said person-centered care is what will make our care incredible. And gradually, we hope that we'll see sort of this sort of change in values and culture. This is one of those things where I think we all went to medical school dreaming about this kind of care. If you asked me when I was in medical school, what did I think medicine was going to look like? I think I would have described something that looks like what happens today, but somewhere along the line, in the drive for productivity and efficiency and numbers and throughput, we've sort of forgotten about that. So at some level, I think it is really about connecting providers back to their own natural aspirations, because doctors and nurses and healthcare providers, we're human beings too, and we have the same needs for autonomy, relatedness, and competence. We also need to make sure that we equip them with the skills, right, so that they feel comfortable. We shouldn't put our providers in a situation where they bring something up, the patient cries, and then they don't know what to do. We need to sort of give them that confidence too.
So leading on from there, from what you just said, right, when you talked about giving people and the providers the skills and the competencies actually to handle this, to manage this well, right? I'd like to ask a lead-on question, which I think is similar to a question that someone has put up on the chat. So I'll ask both of them together. Is that what would it take for this new paradigm to move beyond champions like you and become something that's ingrained internal part of the system? And Fiona asks, what's next for the YOC? So if you could kind of address. And I think there's another question which is kind of very similar to what I've just said. What will it take to effectively change Singapore healthcare system? So yeah, we all have the same questions, I suppose, then.
Why don't you take the first one and I'll take the second one, Tongwei?
Yeah, so I've alluded briefly to that in one of my latest, one of my last slides. So we started off to, learn about this in the diabetes clinic, the specialist clinic in NUH. But very quickly, we have extended this to the polyclinics, and we have Clementi and Pioneer polyclinics coming on board. And we do it also with a rigorous evaluation, in that we also collect data on 2 polyclinics in Bukit Batok and Choa Chu Kang, who carry on the usual way care is delivered. And we do that to compare the effectiveness of this. And we have finished recruitment for about 1,600 patients. And the progress is amazingly well, despite the COVID crisis. And then we will be able to see the results really soon. And then next on, we already have many people within the NUHS expressed interest, and the next From early next year, we will extend this to Alexandra Hospital Metabolic Clinic, where the scope of illness will now expand beyond diabetes to cover some aspects included like fatty liver, obstructive sleep apnea, and gout, obesity. So these are really expanded areas beyond diabetes, because the principles are the same for the long-term conditions. It's just that the specific medical details are a little bit different.
So maybe I'll sort of tackle sort of Jessica's question, which is, what would it take to change the healthcare system? I think there are two aspects of that. I think there's some change that needs to occur within the providers. And you know what, the principles that and the theories that I described earlier on are equally applicable, as I said, to all human beings. And the providers, we need to help them feel that this is something that they aspired to before, but we also need to make sure that we give them the confidence that, first of all, that they are able to do this, and secondly, that when they do it, they're part of a community. So this is the relatedness, right? So we need to make sure that it becomes cultural for the healthcare system, and make sure that we support them. Tong Wei actually does a lot of work in the post-training sort of support, where they actually sort of meet once a month. And one of the things that we discovered is that when we first trained healthcare providers to do this, we maybe painted too rosy a picture, and we sort of sent them out with a message that if you provide care this way, it will work every time. Guess what? It doesn't work every time. And any of you who've had teenage children in the past will know that, when you have conversations with your teenage children, you don't get what you want most of the time. So I think it's really important that we sort of keep people supported. But then at the sort of healthcare system level, we need to sort of think a little bit about how do we engage them in a meaningful way. Just as we're saying, when patients are disengaged, it's because the healthcare system has failed to engage them in a way that is meaningful to the patient. We need to figure out what is important to the healthcare providers, the healthcare system, and the funders. So we need to convince them, for example, that this works. And all this sort of rigorous evaluation, scientific publications, I think is key to that. And I think that's something that we can do within an academic environment that maybe is more difficult to do outside that. I think that's a real advantage. But we also need to sort of evaluate the impact on resources. We need to convince the providers that if we do this, not only do we get better results, we're not going to bankrupt the system, right? But and create this sort of huge long waiting times that people are going to start writing to the forum about and saying that the healthcare system is broken because the waiting time is very long, when what we're really trying to do is sort of provide care in the way that it was meant to be delivered in the first place. What we found is that as we do this, giving people the experience, in my own experience now, when I started off, yes, one of these conversations takes a long time, but inevitably what happens is that these techniques and skills become part of how I do everything. I talk to my children differently, I talk to my wife differently, I talk to my colleagues differently, in a different way, as a consequence of my participation in these sort of efforts. And very soon, I think, it just becomes natural, and it doesn't need to consume huge amount of resources. I think it is implementable without bankrupting people.
Okay, so there is this question from Andrew about if you see more positive results amongst patients who are more educated versus those who are less educated, and what are some of the measures put in place to encourage the latter group to actively participate in this new model?
Yeah, maybe I'll take that. So you remember the second anecdote I gave, the 60-year-old lady who's widowed. She is really an example of a not very highly educated person. And actually, this is not new, that if you look at studies, even in the US or UK, when you do these kind of engagement, usually the more lower socioeconomic group actually will latch on to this much faster, and they will actually see a huge improvement as long as the necessary support is actually given, because they have been long probably in a more disadvantaged situation, and when you start to pay attention to them, they actually do very, very well. But having said that, it is true that some of them need a little bit more hand-holding in order for them to make sense of some of the things. So we actually did also have plans, and we recognize this is a challenge, that we want to also build and also research into what are the other resources that would help this group of patients more effectively. It could be, befrienders, it could be community health posts, it could be health coaches, and these are really tailored for different needs from this different socioeconomic group. But in general, the model works regardless of your education level. It's just like McDonald's when they package the value meals in the US and in Asia, they're actually the same, and it's just that when they have nasi lemak burger here and they don't have it in the US, and people just take it up the same way. They will just top up that $1 to buy the whole meal rather than buying things separately. So in a sense, human needs and behavior are no different in certain ways, and they're different in certain specifics. So as long as we address those, I think they will engage in it in the same way.
I'd like to ask one last question before we proceed to wrap this up. Taking again from both of your answers, Prof. Thai mentioned that this doesn't always work in all patients, and Dr. Yu mentioned something about more research that's needed. So I just want both of you to answer what, in your opinion, are still missing pieces of this puzzle, as in where do you think more research is needed or should be directed?
So I think there are a couple of things that I'll tell you about that we're doing, but I think that there are questions around how to do these things better. I mentioned earlier on this idea that we'll have fewer staff, and a lot of people have said that we need to sort of leverage on digital technology, and we keep hearing this over and over again as we've gone through this sort of era of COVID. And I think that's fascinating, but the questions that we would ask, for example, is that a big part of what we do in the clinic is demonstrate empathy, right? The big part of what we do is sort of talk to patients. And how do you display empathy on a digital platform? It's not evident, and I think there's a lot of experimentation that we can do around the sort of modes of communication to achieve the same kind of psychological goals that we're trying to achieve in a face-to-face consultation. But Tong Wei, you probably have some examples that you could bring up that you would do even in the clinic, right?
Yeah. So, for example, even the results letter, the way we explain what is a HbA1c, what is LDL cholesterol, even that, the phrase, how do we frame it? There are science behind, behavioral theories that, for example, some people are more averse to loss. Some people resonate more with positive gains. And whether we frame the message in accordance or we purposely frame it in the opposite direction, what impact does that have? For example, when we explain the importance of having a good blood glucose control, do you present it in a loss way, which is that if you don't control your glucose, this is the calamities that may happen? Or in a gain frame, where if you control your blood glucose well, you may gain this positive outcomes, these kind of things. And then whether that is framed in a manner that fits the person's inclination, or it goes against the person's inclination to shake them up. All this, which way is more effective, are also an area for minor tweaks and a rich aspect, really a good aspect for further research and interrogation.
Thank you so much. And I would like to now hand over to Jamie to conclude this session.
Thank you, panel speakers, for insightful sharing. To our audience, we hope you have enjoyed today's webinar. If you have questions we didn't get to answer, please contact us at the address shown on the screen. We'll send you the link to the webinar recording after the event. The speakers will also stay back after this to answer any other questions you may still have. Your feedback is important to us, so please scan the QR code shown on the screen for a short survey. We will also send you an email link to the survey. Thank you for participating in today's webinar, and we hope to see you again next time.